Good evening, dear friends. Today, the topic of discussion is polycystic ovary syndrome, and another topic I've added for the benefit of all, hysteroscopic management of RPOC. I am a consultant gynae. Basically, I'm doing endoscopic surgeries. I'm practicing at ND Hospital, Hisar, Haryana. So today we will be studying the aspect of PCOS overview. Though we all know, but we'll see what are the changes that has been made in the definition of PCOD by the recent guidelines, role of primary care setting, and how does that primary care setting get the early diagnosis, and how it will help in the management of PCOS and the treatment of PCOS, and also the consequences of delayed and improper PCOS management at primary care setting, and need of patient counseling. That is the utmost baseline and important thing of the PCOD, which we must take care. And in the last, I will summarize. So this is what is classification says, what is polycystic ovary syndrome. Polycystic ovary syndrome, it is a commonly a disorder, endocrine disorder of reproductive age group. As we go past near menopause, the PCOD is wane because the ovary size decreases. So the incidence of PCOD decreases as the women approaches near the menopause. PCOD is defined by the combination of sign and symptom of androgen excess and ovarian dysfunction. All the sign which and symptom the patient face are due to androgen excess and the dysfunction in the balance of estrogen and the progesterone level. So what happens in this? There are three basic changes which happens. There is a clinical biochemical evidence are there of elevated androgen levels. There are presence of multiple cysts on ovaries, which we call PCOD ovary. Whenever it is reported in the PCOD, multiple cysts are seen, it is reported as the PCOD. Menstrual irregularities that can be in variable form will be seen in the future slides. This is how the PCOD happens. It is the basically the insulin resistance that lead to all the hormonal imbalance. It acts on the ovary. It lead to excess production of estrogen, androgen, and estrogen. And biochemically, they will be seen as elevated level of FSH, and LH is twice as high as FSH, as the androgen is being produced more in the body, and which causes all the disturbance, the feature of a hyperandrogenism, the hirsutism, the acne, delayed cycle, difficulty in conceiving, and the long-term consequences also type 2 diabetes mellitus and endometrial hyperplasia, and there are many other impact cardiovascular on health. So what are the signs and symptoms which the patient comes usually with when they are suffering from the PCOD? It is on the ultrasound that we see the ovaries are enlarged with numerous cysts. Otherwise, they tell us their irregular menstrual cycle. Hirsutism is a very common complaint in today's young population, adolescent. Alopecia also, they will tell you that they are having excess hair fall. So we just should not ignore this symptom also, because they are it is a also this symptom of a PCOD. Acne, acanthosis nigricans, these is basically seen in very obese patient. It is a sign of insulin resistant, and there are some skin tags also. Sign and symptom, as we have already discussed. How do we define the PCOD? PCOD is defined as whenever there are excessive follicles, which are defined as 20 or more follicles in each ovary, which are of size of 2 to 10 mm. Additionally, by volume also on ultrasound, we can measure that if the ovaries, both the ovaries, it is more than 10 ml. Sorry, it is written by mistake 12. It is, I've just checked from the recent guideline, it is 10 ml. If it is, then we classify that as a PCOD on ultrasound. And what the menstrual disturbances that the patient can have. So menstrual disturbances, we should be very cautiously classifying the PCOD in young patient when they are just attained the menarche. In the first year, when they've attained the menarche, any irregularity is considered normal. So if a patient is coming at a very young age, which and when she has attained menarche less than 1 year, so any abnormality in the cycle should be taken as a normal part of the hypothalamic pituitary axis maturation. And after 1 year and less than 3 year post menarche, the cycle can vary from 21 days to 45 days. For that age, 21 to 45 days cycle should be considered as regular. And if you are 3 and anything which is beyond that should be considered irregular, whether they are less than 21 or whether they are more than 45 at this time junction of their post menarche should be considered as abnormal. Or otherwise between 21 and 45 it should be considered as normal. And when they are 3 year post menarche, to perimenopause, then the normal definition applies to them, that 21 to 35 days cycles are considered normal, and anything which vary from this is considered abnormal. And after 1 year post menarche, if they are not having periods for almost 3 months, that is also not considered as a sign of menstrual irregularity. And if the patient has not attained menarche by the age of 15 or 3 year post menarche, that can be also a sign of PCOD. Health implications, we all know PCOD, in the reproductive age group can cause infertility, and when they're pregnant, they predispose the patient to preeclampsia, and they also tend to have more miscarriages. Metabolic, if the patient has obese, her BMI is more than 25, she will show the feature of insulin resistance, and eventually these patients are more likely to develop type 2 diabetes. Dermatological, these patients can have hirsutism, acne, hyperpigmentation, and hair fall, as we have discussed earlier. Neurological, they have sleep disorder, because these patients are also suffering from psychosocial symptoms, and they're very anxious patients, and they also do suffer from sleep disorder, sleep apnea, or they even have eating disorders. Psychological, they can be having anxiety and depression. So a multidisciplinary approach is required to treat these patients, not only the gynecologist, the involvement of physician, the psychologist, behavioral change therapies, all is required. Epidemiology, we all know it has been on rise. It is very much increasing in India also, from 3.7 to 22.5%, depending on the population. In my routine practice, I've seen that the PCOD has been on the rise, and it is rising very rapidly. It is like an epidemic of the PCOD we see in our clinical practice. What are the risk factor? There is a genetic involvement also in the PCOD, because many times the patients come which are very lean and thin, still they have the PCOD, they are maintaining good healthy lifestyle, still they have a PCOD. So there comes the role of the genetic, that it has some relation with the genes that also causes a PCOD. Lifestyle, we all know unhealthy food, sedentary lifestyle, and smoking, drinking habit, these all contribute to the formation of PCOD. Obesity, it is very important contribution for the PCOD. The sedentary lifestyle, lack of physical workout lead to obesity, and the obesity leads to PCOD. However, a patient thinks the other way. They think they had a PCOD and that's why they are having the obesity. Partially it is true, because PCOD, what happened, it decreases our basal metabolic rate, and then again these patients tend to increase the weight more than the usual patient. But earlier in the initial part, it was the obesity which lead to the PCOD. Environmental factors, the environment in which we are living, we are inhaling so many toxins, we are eating chemicals through our food, through these fast foods, and even the green vegetables and the fruits which we are taking from the market are not free from chemicals. So what are the diagnostic tools? I'll just for the ease, we normally follow ASHRAE and ASM Rotterdam criteria, that the patient, if has 2 out of these 3s, can be considered to have a PCOD, a feature of hyperandrogenism, that can be clinical or biochemical or and ovulation. And on the ultrasound, these diagnostic criteria, we all know we have to take 2 out of the 3. So to reach, hello, am I audible? Hello?
Hello, yes ma'am, you are audible, please continue.
So how to make a diagnosis of the PCOD? It has to be by patient history, the patient menstrual history, and her fluctuation, bleeding pattern, and recent weight gain that she had. Physical examination, again, when the patient come in the OPD, if she is having so she's obese, the look of that before she uses nitrogen, the black pigmentation which is seen on the neck and in between the chest and on the under armpit, etc., under the breast, these are the areas where this hyperpigmentation happens. Laboratory measurements, the level of androgen, total biochemical of free testosterone, dihydroepiandrosterone sulfate. This has to be done if the patient is having the clinical feature of the hirsutism. So we have talked, we will not discuss much about the hirsutism, but otherwise it will go very lengthy. But we know if the patient present with hirsutism, we have to get her testosterone, whether we have to get androgen index, free testosterone, total testosterone, and dihydroepiandrosterone sulfate to see whether it is from androgen, what is the source of excess androgen in the body. It may be the ovary, it may be the adrenal, or it may be some other tumor in the body which may be secreting the excess androgen. So we have to get the whole workup. If the patient has a high symptom of clinical virilism, the whole ultrasound, whole abdomen, even if we are suspecting some tumor, MRI, CT scan can also be ordered. And also we have to distinguish these patients from the patient of congenital adrenal hyperplasia. So there can be many PCOS phenotype. They can be hyperandrogenism, ovulatory dysfunction, hyperandrogenism, PCOD on ultrasound, and oligovulation, PCOD morphology, hyperandrogenism, oligovulation, PCO, all the threes are present. So there can be various combination. It is not necessary that the patient will show all the three symptoms. So differential diagnosis, as I've said, adrenal, ovarian, androgen secreting tumors when the patient has presented with high features of the virilism. Non-classic congenital adrenal hyperplasia, or to distinguish this, when these testosterone and these DHEAs are elevated, then we have to get the 17-hydroxyprogesterone level to differentiate it. Hyperprolactinemia, these patients also do present, the ultrasound picture is like of PCOD. So measurement prolactin level is suggested whenever there is delayed cycle. Thyroid dysfunction and premature ovarian failure. Also, this is very important when the patient is arriving almost, we should get the FSH, because it distinguishes the subset of patients which are suffering from premature ovarian failure, which we mistakenly diagnose them as PCOD. So we have to be very cautious in making the diagnosis of PCOD. We have to exclude all these conditions. Treatment of the PCOD, there is no universal or no one thing which is very successful. So we have to multiple disciplinary approach. It has to be, and the treatment should be chronic and dynamic, and it should be in accordance with the person desire, expectation, lifestyle. So we have to individualize the treatment. One treatment does not fit all the patient. Treatment of pharmacological, it is like we have to treat androgen excess, whatever the symptoms are, oligovulation, whether she's suffering from the type 2 diabetes, etc., or infertility or recurrent miscarriage, the treatment has to be individualized. So the pharmacological approach to PCOS involve treatment of these things. Symptoms we have to treat, again, infertility, menstrual irregularity, hirsutism, acne, insulin resistant, obesity. It will depend what age of the patient, what her marital status, she's married, non-married, what is her desire, she wants pregnancy or she doesn't want pregnancy, or she's what are her main complaint, what is the thing that is troubling her the most. So we should focus on that. Pharmacological therapies for infertility, we give ovulation induction. For menstrual irregularity, OCPs are being given, insulin resistant, metformin, and other insulin sensitizing agent can be given. Hirsutism, acne, OCP should be the first choice, and it should be used as a single agent. Only those patients who are not accepting the OCPs, then the other things should be tried. Endometrial hyperplasia, we can give them the lifestyle modification, and again, levonorgestrel is good, but before it is not acceptable to all the patients. So oral progesterone, as we are usually treating a patient of endometrial hyperplasia. So now the roles of minoxidil and other this antioxidant therapy. How does they work? This minoxidil is an emerging therapy, and it has been more than 10 years that we are using this salt for the treatment of the patient of the PCOD, especially in the patient who wants to get pregnant and obese. Role of minoxidil in PCOS, it is said they are insulin sensitizer, so they enhance the glucose uptake in the cell and their utilization and convert into the other molecules. So the feature of hyperglycemia are not there. Insulin reduces the insulin resistance. In that way, that is the mechanism by which they reduces the hyperandrogenemia. Supplementation of minoxidil in combination with folic acid prove different in endocrine metabolic alteration and some reproductive parameters associated with PCOS. It is helpful in improving oocyte quality and maturation, reproductive prognosis, and other associated metabolic risks. Various studies have suggested that minoxidil can be considered as an effective and safe treatment for obese and non-obese. It works for both, as opposite to the metformin, where it is said that metformin should be given in a patient who are obese and who are showing the feature of insulin resistance, but minoxidil can be given to both obese and non-obese women. who are showing the feature insulin resistant and hyperinsulinemia. Foxy recommend the use of minoxidil adjuvant therapy for ovulation induction in patient with requiring assisted reproductive technique due to several health issues like PCOD. So mainly in the patients of infertility, those who are taking treatment for fertility, minoxidil can be added. And it is a good therapy. It is an antioxidant. It will do only good to the patient. I think there are no side effects of this minoxidil therapy. So there is study also which has been conducted, and it has been published in Gynecological Endocrinology 2007 January article. This study, they have studied 25 women who are having PCOD, also the feature of oligomenorrhea for 1 year. In these patients, they have given 2 grams of minoxidil folic acid combination twice a day for 6 months. They have seen the number of patients with menstrual cycle after treatment who have improved 22 out of 25, that is 88%. And the number of patients who restored monthly ovulation, 72%, number of pregnancies 10, number of pregnancy, the ratio is 40% pregnancy rate. Number of pregnancy versus number of patients with restored monthly ovulation, 55%. So they have seen significant improvement in all the things, parameters, regularization of menstrual cycle, improvement in fertility rate and pregnancies. There is another study which also show similar result, that there has been increase in the pregnancy rate. So other than non-pharmacological therapies, what we can suggest to our patient is lifestyle modification, which is, I think, the mainstay. We should just not, first thing which we should be suggesting our patient should be the lifestyle modification, because that is the cornerstone, the base or the real management of the PCOD. You have to educate your patient that the PCOD is a lifestyle disorder. It is due to, because of disturbance in the lifestyle, the change in the habits, because there is less physical work and eating habits has changed. So we have to educate the patient. The exercise, the physical activity is the necessity of the body, and if we don't do these things, then our body will show its symptoms in the form of PCOD. So they have to they have to do physical activity, maintain the weight, dietary habit has to be good, and avoid the tobacco use. So if it is required, we can also refer the patient to the dietitian so that she can make an appropriate diet. And these patients are suggested that they should be given around 1300 to 1500 calorie per day diet, and it should be also depend on the total daily requirement of the calorie of the person, and it has to be 30%. They have to be in the calorie deficit. It is mentioned in the ASRM guidelines that the patient has to be advised diet, and it should be 30% negative calorie deficit. Then only her weight will reduce. And there should be physical activity, at least 120 minute vigorous activity. This is per week. And if she's mild to moderate, she's doing physical activity, then the this minute increases. And it is ideal that you can tell your patient that she can have a 10,000 steps per day. That is also ideal. And she can do 30 minutes of vigorous activity. So all these things help actually. Reduction of excess weight and maintaining healthy BMI. This is utmost important. Even if you are not having PCOD, I consider that we should be all maintaining our BMI in a healthy range. Ketogenic diet, fiber rich, low. What is the diet that reduces the PCOD? It has been seen in the studies that it is the protein which will help basically to improve the PCOD. It is protein rich diet it should be, because protein helps in building our muscle, and when our muscle strength will be good, the PCOD, the insulin resistance goes down. And when the insulin resistance goes down, the incidence of diabetes, PCOD, hypertension, everything goes down. So we should be taking good amount of protein. We Indian are actually vegetarian. That's why the vegetarian diet lacks the protein, and because of which the majority of population is going towards obesity and PCOD. And obviously the unhealthy habits, smoking and alcohol, they should be minimized. So this is again the treatment algorithm which we have discussed. The acne, local antibiotic or benzoyl peroxide can be given, or if they are having a severe form of acne, they can be referred to the dermatologist. Role of primary care physician: the person whom the patient contact at the first level is making the diagnosis, determination of what are the risk factors, then telling her the prevention of these things, and then focusing on the treatment which is required. But what are the gaps which are seen in the PCOS management is that it is there is sometimes delay in the diagnosis. There are so many diagnostic guidelines which confuses people how to diagnose the PCOD. Either it is overdiagnosed or it is underdiagnosed. Multiple consultation, lack of awareness, patient has to be educated fully, and she reads too much from the Google, and then she get frightened, and sometimes the patient come and they are too much frightened that now they have PCOD, they won't be able to get pregnant. But at the 18 year, that is I think patient should not be subjected to think that. Instead they should be the thoughts that they have to be attain optimum weight according to their BMI, and their diet has to be good, their physical activity has to be good. These things we should inculcate in the patient mind, rather than creating a fear of infertility or endometrial hyperplasia or endometrial cancers. We should not be feeling those things in their minds. What I feel, lack of patient education material or whatever is available to them, that is of low quality. Difficulty in patient education, failure to design, and these patients need lot of time. They need at least 20 to 30 minutes of counseling, which is not possible in Indian setting when you are having a heavy OPD. So there can be some counselor in your hospital for these patients who can tell them all these things in a detail if you don't have the time. Failure to design personalized goal, patient's adherence. Now what is the why there is a delayed diagnosis? Because there is no single diagnostic test. Unavailability of ultrasound in primary care setting at the level of village, variation PCOS because of ethnic, genetic, and environmental factor. Difficulty in diagnosing during adolescence. Adolescent, I have clearly mentioned that how much should we take that the cycle irregularity is very common at young age, immediately post-menarche. So these things should be kept in mind while diagnosing PCOD at a younger age. Lack of knowledge in patient about which medical specialty to consult. Consequence of delayed diagnosis are like psychological issues. They will have all the complication of the PCOD, along with that psychological issue, anxiety, depression, loss of confidence. So we have to all manage them. Patient education is very important. I've already told we should educate patient that this is a lifestyle disorder. It will not go with the medicine. Medicine can only help them for the time being. It is the only patient who can improve her health, and we have to tell her the measures how she can improve her health. Conclusion, PCOD is a common endocrine disorder. It is frequently associated with abdominal adiposity, insulin resistance, obesity, metabolic disorder, and cardiovascular risk factors. The main factors, genetic, diet, and other lifestyle habits, environmental agents are leading to the PCOD. Diagnosis based on presenting symptom and application of evidence-based diagnostic criteria, which we have already discussed. Pharmacological therapy, lifestyle modification, diet, exercise, weight control are necessary in the PCOS management. Primary care physician play an important role in diagnosis and treatment of PCOS, so they need to be educated. Patient education, awareness material should be freely available to the patient, and it should be given to the patient. Thank you so much. And I'll just take 1 minute, just 30 seconds. PCOD is a very common problem which we all face, and sometimes it is very difficult to explain all the to the patient, to her mother, that what has been happening. Sometimes the patient is coming in very distressed mood. She has been explained about all the risk and consequences, and she has been put on too many medications. So we should try to simplify our approach, make patient comfortable, and realize her what is the actual problem and how can she improve herself. So we'll next move on to our next topic, RPOCs, retained product of conception. This is again a very common problem. There is a lot of miscarriages. These days, the miscarriage has been increased, and they are also seen after MTP. Pills the patient take from here and there. So retained product of conception is defined as a persistence of placental fetal tissue inside the uterine cavity after the pregnancy. RPOC, it complicates 6% of all pregnancies, and it can be seen following medical, surgical termination, spontaneous abortion, vaginal or cesarean delivery. What are the symptoms which are associated with the RPOCs? It is the persistent bleeding the patient presents with, pain, abdomen, foul smelling, vaginal discharge, sometimes fever, delayed symptoms. If these things are not treated, neglected for very long, even she can present with the delayed symptom like secondary amenorrhea and infertility due to adhesion. diagnosis. Ultrasound play a very important role in diagnosing retained product of conception, but there is no set criteria on the basis of which you can say this patient has a RPOC. Various studies quote a different thickness of the endometrium for the retained products, but what has been most commonly established is when you see the thin lining of endometrium, it rules out the presence of RPOC with 100% accuracy, and the thickness of more than 13 mm or greater is indicative of retained products. But what I have seen in my clinical practice, even when there is a small RPOC, it shows as a heterogeneous echogenic shadows, which can be even 7, 8 less than 10 mm, and so you have to make the diagnosis in accordance with the patient history. If the patient is giving the history of persistent bleeding or pain in the abdomen and foul smelling discharge or brown discharge, in ultrasound, if there is reported some heterogenic area, they can be very well chances of RPOC. So it has to be diagnosis has to be made according to the symptom of the patient. Hysteroscopy, whenever you are suspecting pathology like polyp. Some of arthroscopy look like RPOC look like. Once you start doing hysteroscopy for RPOC, it is just a one case. You will identify this is a RPOC, and then you will not miss in any case on hysteroscopy of RPOC. It is like a whitish material. In this case, it does not have any vascularity, so it is totally a whitish, roundish this polyp-like attachment. This mass in the endometrium, hysteroscopy, and this is the type 1 RPOC. It has a mild vascularity. It has some vessels, and this is the type 2, which is a high vascularity RPOC, which we are seeing as a villi or frond-like appearance. And even on ultrasound, these patients, they show the increased vascularity, which is even reaching to the myometrium. So there is a classification which has been popularly used by Gutenberg classification. It is said it uses the ultrasound pictures for classification RPOC. Type 0, where it is hyperechogenic avascular mass. Type 1, different echoes but minimal or no vascularity. Type 2, highly vascularized mass, which is confined to the cavity. And type 3 is highly vascular mass, which highly vascularized myometrium. Type 2 and type 3, they need to be differentiated from AV malformations and a persistent trophoblastic disease, which can also show a similar picture. So beta SCG is also mandatory in such conditions. So treatment is by medical management. The traditional D&C has been done, and the newest and the established and most harmless way of treating the RPOC is the hysteroscopic removal of RPOC. So how does what does the D&C do? We have seen that D&C, the repeated D&C, has been is being practiced for RPOCs, because after when you are doing D&C, there are high chances that the POCs will still be stuck at some point, and because of the D&C, the trauma is caused to the endometrium. The granulation tissue form on both the layers. When it form on the opposite side, opposite walls, then these intracavitary granulation tissue, they fuses to form the fibrous tissue bridges, which leads to adhesion, and sometimes they can be severe Asherman, and these patients are not able to conceive in their future reproductive years. Formation of adhesion is estimated to be 15 to 40% with blind D&C. Post-adhesion sequelae, Asherman, we have already discussed. And if somehow these patients, their mild adhesion or something like that, and these patients become pregnant, they can be obstetric complications also, like placenta accreta, placental abnormalities, preterm deliveries. They are also very common with intrauterine adhesions. Now, what is the comparison between a D&C and hysteroscopy? D&C is a blind method where hysteroscopy is a precise removal without damaging adjacent myometrium. Incomplete evacuation chances are 28%. They are nearing 30% in D&C, so it will be requiring repeat D&C. Hysteroscopy, the incomplete evacuation chances are very, very, very less. It is just 1.4%. The chances of adhesion formation after D&C is 15 to 40%, as reported in various studies. Increased chance of uterine perforation, bleeding, endometritis. We have also seen post-D&C iatrogenic AV malformations, and it is very difficult to treat these patients. These patients suffer from very serious bout of bleeding that can be life-threatening. And hysteroscopy, chances of intrauterine adhesion are very less. It is seen 0.8 to 12.8%. And it is a very satisfactory procedure, hysteroscopy, because once you are doing hysteroscopy for RPOC removal, you are very sure these patients that you have never, there is no residual RPOC. And when these patients even return due to some bleeding problem, you just manage them by giving hormonal problem, because you are very sure that this patient doesn't have any retained products. So I'm just sharing one video of a patient who had taken MTP kit, but her this product does not get expelled. There was a whole mass which was stuck to the, and this patient came after 2 months of taking the MTP kit. She was persistently bleeding. She has taken multiple times the mesoprost for the medical management, but her symptom does not get relieved, and even the ultrasound picture get worse. It was showing highly vascularity which was reaching to the myometrium. This patient also had to undergo the tubectomy, so I've given the vasopressin to reduce the vascularity. Then the cold scissor was simply used to attach this RPOC from the wall, the similar way we do for the polypectomy. See the vascular portion, these vessels, coagulated vessels are seen here. And then I was just going parallel to the anterior uterine wall and detaching these attachment of the RPOC, but was very fearing if there can be some bleeding. Whenever there is a avascular mass, you can go and confidently remove it with scissor, nothing will happen. But you have to be very cautious when there is bleeding. There is vascularized mass, so you have to take measures to prevent bleeding. You can instill the vasopressin in the cervix, or if you are doing simultaneously laparoscopy for tubectomy, you can instill the vasopressin in the myometrium. Then I have used loop of electrode resectoscope to seal the coagulation point. So because I don't want any bleeding in a post-op period, this was not very necessary, but that was done just as extra precautionary measure. This RPOC was then dragged with the loop of the electrode and it came out very easily. So normally whenever I do hysteroscopy for any return product, it is usually seen the POCs are stuck to in a form of polypoidal mass to one part of the uterine cavity. Mostly they are at some angles, so they are like a focal pathology. And when we are doing D&C for such patient, there are high chances that some product will be left behind. So the hysteroscopy is the best method. It will not damage her endometrium, because we are just cutting the attachment of those RPOC polyp from the uterine wall. We are not damaging the endometrium from anywhere else. So these patients, especially those who had to take the chance of pregnancy again in the future, they should be treated with hysteroscopy. It will help and prevent a lot of complications which are associated with D&C. So the study says, some people say we'll do the ultrasound guided removal of RPOC, but the study has said that the ultrasound guided removal of RPOC may result in lesser chances of residual RPOC, but it does not decreases the chances of adhesion formation, because the blind D&C, you curate all the walls that create the ulceration in the endometrium, damage the bacillus, and that will lead to the formation adhesion. So only the hysteroscopy, by the use of hysteroscopy, you can prevent the adhesion formation. Recently, even the AAGL, is an American Association of Gynae Laparoscopic, has given the statement that intrauterine adhesion state the incidence of intrauterine adhesion is higher or in technique D&C related to surgery under direct visualization for the removal of pregnancy related pathological conditions. So it has become the established method. You are not doing any harm by doing the hysteroscopy. It has been established as a gold standard method for removing the RPOC. Take home messages: hysteroscopic removal of RPOC is a one-time risk-free fertility preserving procedure when compared to blind D&C. Treat RPOC with hysteroscopy and prevent Asherman syndrome. I hope both the topic has been very useful to the people who are listening to me, and it will help in some way to change their management and treating their patient, especially in the case of PCOD and RPOC. Thank you so much.